Hi, everybody.
Hi, Alyssa. I'm trying to get back on. I went off to look at something else, and then I got lost coming back on. So
Oh,
yeah,
no.
I know, I know. Alyssa, life is filled with hard things.
Yeah, today was a day that was technologically a difficult one for me, so I can relate to you right now.
So you're on an admin account from your work?
Oh, yeah, let me change my name. I get to use all the work accounts.
All right.
Yeah, we're a small place, so
Yeah,
using the work account is a little different here.
yeah. So before we get started, Jacob, it's good to see you.
Hello.
You're coming as a member of the public and decided this isn't a good time for you to join the board. Is that correct?
I am, yeah. After more kind of thought process with it, I've decided that there would be a conflict of interest on my end, and recusing myself from that.
Yeah, I understand that, and I'm glad that you're here, able to say that, and I just don't have to say it. I really appreciate you coming here
Of
when we
course.
when we bring that up. Okay. I'm trying to look. Well, my clock says it's 12:15. We're still waiting for a few more people, particularly board members. Emmy contacted me and said she has a conflict with an important thing, and that Paul Bernanke is also at that meeting. So that maybe make Jack and Jeremy the senior staff members here. And so I'm not assuming any of you will make any comments about the reports that Emmy or Paul would be here. And so
Tim, actually, she did send some information to Jack and I to share with the group. So we have a little bit of information from Emmy.
okay, good. So when you get to that time, then you'll share with us. Thank you. So is Connie Beck going to be able to join with us? Laurel, do you know? Okay, Laurel must be off doing something important. So it looks to me like we can get started here. So I would like to call a meeting of the Humboldt County Behavioral Health Board into session. I want to welcome everybody. This is our regular monthly meeting, and we are again the advisory board for the Board of Supervisors. We hold this meeting on the fourth Thursday of each month, and it runs from 12:15 to 2:15. The minutes and agenda can be found on Googling Humboldt County Behavioral Health Board, and you'll find such information within a list of committees. This is a public meeting, and everyone is invited to attend. We provide time for public comments, and I will say more when we get to that time. So please note this meeting is being recorded. If you are not comfortable with that, then we can pause the recording for the public for their comments or accommodate what is best for you in that process. So we're going to move on. We start every meeting with a roll call of board members, then introduction of staff, and then members of the public. We ask you to use your preferred pronoun if you can remember that, and you can give us your name if you're a member of the public or not if you would not like to do that. So Joe is our secretary. You want to call the roll for the board members?
Sure. Alyssa Norman,
She, her, here.
Nora Montagna, Steve Madrone.
He, him, here.
Okay. Tim Ash, Tim Doty,
Here, he, him.
Madison Flynn, Allison
Here,
Tans,
here, this is Madison. Here, I use pronouns she and her.
Allison Tans,
I'm here, she, her. Thank you.
Debbie Hartridge,
Here, she, her.
Colleen Broderick, Isabella Watherspoon, Danette Kellerman, Vernon Price, Gardner Carlson is excused. Oscar McGowan is excused.
Thank you. Oh, here comes Tim Ash. Welcome. So
Good afternoon.
good afternoon. I'm assuming, Joe, that we do have a quorum.
Well, we have 7 out of 14, so we need one more.
Oh, that's right. We can have this meeting, but we can't vote, officially vote on anything. Pretty much it'll be discussions and informational. I'm looking to see who's just joined us. Well, I hope someone else will join us. We don't have major things. I'm seeing chats. I'm not too good at that. Is there a chat about? Oh, Laurel, you can't find your microphone. Okay, and Connie is coming, and I'm in a parking lot, and okay. I am not good at doing chat.
I can watch it for you and make sure that if anything important pops up, I'll mention that. How's that sound?
It sounds good. You are the third vice chair, and
That can be my official duty.
that's right. Okay, so we are here.
Excuse me, this is Laura Montagna. I'm on audio only.
Great.
Okay, so we have a
Great
quorum.
to have you, Laura. You make the 8th person, and we are now a quorum because of your commitment.
Cool.
So,
Sorry.
no. We're so glad that you're here. So that's the board members, and let's go right ahead and introduce the staff. Please let us know who you are and what your job is. And if you have a grid there, why don't we start at the top and see how well we can do. Oliver, that would be you first.
Hi, my name is Oliver Gonzalez. I am the program manager for the Mental Health Services Act here in Humboldt County.
Yeah. That would be you, Jack, on my screen.
My name is Jack Brazil, Deputy Director for Behavioral Health.
I think that would be you next, Jeremy. I'm doing this wrong. It's not helping.
That's okay. I think we'll have different order of who's on our screen. So
Right.
My name is Jeremy Nilsson. I'm the Deputy Director over Children's Behavioral Health for Humboldt County.
Thank you. I see you, Sonia.
Hi, everyone. Sonia Levy-Boyd. I supervise the Humboldt County Transition Age Youth Collaboration and the peer coaches at the TAY Division. I use
Great.
she, her pronouns.
Thank you. I see Kathy.
Hi, everyone. I'm Kathy Rigby. I'm working extra help part-time, assisting Oliver in his new role, and my pronouns are she, her.
Thank you. I see Brianna next.
Hi, I'm Brianna. I'm the new Senior Program Manager for the Healthy Communities Division over in Public Health.
Thank you. I see Christine.
Hi, Christine Messenger. I'm with DHHS Communications.
All right, thank you. I see you there, Connie.
I'm Connie Beck, the Health and Human Services Director. Good to see you all. My pronouns are she and her.
Okay, I see you, Alex.
Hi, I'm Alex Oliveira. I'm an MHSA and QI admin analyst, and my pronouns are he, him.
Okay, thank you. Sharon, I see you up there.
Hi, Sharon Wolf, a DHHS legislative analyst. Happy to be here with everyone. She, her. Thanks.
Thank you. Laura Coulter.
Hi, I'm Laura Coulter. I'm Jack's assistant at Behavioral Health, and I just listen to these meetings typically, and usually I'm on the phone here or having my lunch, so that is why my camera is not on. And I prefer she, her.
Thank you. Aaron.
Aaron Zoe, Budget Projects Analyst, DHHS, he, him.
Okay, thank you. I see you, Laurel. You want to introduce yourself? Okay, I think there's a microphone problem there. Megan, are you staff? Or are you a member of the public?
I'm a member of the public, Tim.
Okay, great. Glad to have you with us.
Thank you for having me.
You're very welcome. Glad that you're here. So that's what I can see as staff. Is there anyone, other staff members here I've missed? All right, we're glad that you're all here. I said to some that Emmy and Paul, Emmy, the Director of Behavioral Health Department, and Paul is a Deputy Director, are at another meeting and are not able to participate with us. So members of the public, would you like to introduce yourself?
Tim, this is Megan. Since you already called on me, I think I know most of the folks on this line, but my name is Megan Harden. I'm with Hospital Council of Northern and Central California, working together with the hospitals in the county on a crisis triage proposal for behavioral health and substance use disorder. Unfortunately, I have to jump at 1, but I'm hoping to see Commander LaFrance's CSAT presentation. Thank you for having me.
Okay, I'm glad that you're here. And so I just saw a chat from Laurel, and she's not able to join us right now. We have another member of the public here, Katie.
Good afternoon, Katie Wilson, psychiatrist.
Glad that you're here. So are there other adjustments to our agenda?
Yes, this is Laura Montagna. I'm not sure if I missed any adjustments, but I'd like to remove action item 5C as that application has been withdrawn.
Yes. Then for information that Jacob is with us and he's interested in just sharing very briefly about that. All right.
Hello, yeah, my name is Jacob Rosen. I rescinded my application to be on the board, and upon further analysis, as much as I would like to provide more advocacy for the community, in my current position with Crisis Alternative Response of Eureka and the city of Eureka, I feel that it would be a conflict of interest to be collaborating with behavioral health at the level that we will need to collaborate, and then also playing a regulatory role. So I recuse myself in my application from that position.
Okay, thank you for your interest. Sorry we'll miss you, but thanks for coming and sharing with us. 2 other members of the public who would like to share at this time. Public comments. Okay, Katie, would you like to introduce yourself and make a public comment in general about our agenda and what we do?
This is Katie Wilson, Tim, and I'm not sure if you're talking to me, but I'm just here to listen.
Okay, yeah, I think I was talking to you, but I can be confused. So I'm glad that you're here. Any other members that I might have missed of the public who would like to share a public comment at this time? All right, I have a longer speech about that, but since I'm not seeing anyone else, we'll go ahead and move on. So the next action items, number 5A, is the approval of the minutes from our 9/22 meeting.
I make a motion that we approve the minutes as submitted for the 9/22 meeting. Laura Montagna.
I second that vote. Alyssa.
Okay, thank you. Are there questions or typos that you might find on it, members of the board?
It looked clear, but I might have missed something, but it looked clear.
Okay, thanks. All right, I hear no concerns or objections. All in favor of approving the minutes, say aye or raise your hand.
Aye.
Okay, thank you. Item B is something that we do regularly. It's approval to pay the California Association of Local Behavioral Health Boards and Commissions. We have a budget for that. It's $800. We've talked a lot about them. We've been involved with them. They're great training, providing guidance for us. So I'll entertain a motion to pay our dues.
I'll make a motion to approve the dues for Cal BHB. This is Laura.
Hi, Laura. Allison spoke first. You can second it.
I second it.
Thank you. Everybody ready to vote? All in favor, say aye or raise your hand.
Aye.
All right. Great. And so the item C has been removed and Jacob was able to share with us. So when it comes to discussion items, our November meeting is moved forward a week because of Thanksgiving. That's kind of, oh, Madison, I see your hand up. I'm sorry.
No, I was just voting.
Oh, okay. Thank you. Thank you. So moving our meeting up to 11:17 because there's a holiday on 11:24. Any questions or concerns? To me, it's kind of an automatic thing we do.
I will not be in attendance for that
Okay.
meeting.
Thank you for letting us know. Appreciate that.
Tim,
Yes.
is it in person, the next meeting, or is it on Zoom?
Yeah, I was going to address that. It's probably a good time to do that. At the executive committee, we decided to start our meetings in person. I brought that up with you at our last board meeting. So our next board meeting will be in person and on Zoom. The location used to be at what we call the Rainbow Room, and it's no longer. So we're going to what's called the Pro Building, and that's at 507 F Street, corner of 5th and F. The meeting goes upstairs on what's called the mezzanine conference room. There is an elevator for those who desire it or need it. It's not too hard to find. Sometimes it's hard to get parking to be there. So questions, Steve, I see your hand.
Thank you, Chair Doty. Unfortunately, I'll be out of town on the 17th of November at the state county conference. So I apologize I won't be able to attend that in person.
All right.
Unless we're doing hybrid.
Yeah, we are doing hybrid and
perhaps. Okay, well, I'll do my best to attend.
Okay, so yeah, it'll be a Zoom meeting as well as in person. What I understand that the best kind of high-tech equipment for that is in this conference room, and there's something called an owl. I have a large screen, an owl. I just learned about that, and it kind of can move around and look at other people who are there, and as you talk, and that's about all that I know. And I was at the Board of Supervisors the other day. The public could only call in, but I think we're going to continue to try to have Zoom participation so we can see you as well as you seeing us. So anything else to say about it's an experiment, but it's kind of getting back to where we were. Oh, let me say this as well. I was talking to Joe. In the past, handouts were made available primarily by showing up, but we're going to do that as needed, but we're also going to make them all available as we do all of our other on the web for internet connections. Any more questions about this meeting? The county strongly recommends that you wear a mask, but it is not a requirement anymore. Is that correct, Jack or Jeremy?
Yes, that's my understanding for that space.
For that space. Other places that are considered more medical, it's required. Yeah.
Correct.
Okay, any other thoughts or questions? As I say, parking is an issue. The staff up there take their lunch break at that time, so we don't let Joe do that, but somebody will greet us. And I remember talking to Michelle, and she said she could adjust her lunch and greet us and work with Joe and move tables around. So we'll move on from there then. So the next discussion item is to just share with us about the MHSA schedule update. And so people were asking about that. Oliver's new, but he's conferred and can say something about the schedule of the different steps in the process. Oliver.
Yeah, absolutely. And if you guys don't mind, I'm going to do a quick screen share. That way you can follow along with what I have going on here.
Okay.
So as you guys will see, from November 2022 to January 2023, I'm going to be preparing the draft of a 3-year plan for 2023 through 2026. And then I'll be conducting 10 to 15 stakeholder input meetings For those of you that aren't familiar with a stakeholder meeting, that's just me meeting with people from various backgrounds and various locations within Humboldt County and getting their input and opinions on the MHSA programs that we have here, and pretty much having that adjusted in the plan as well. For February 2023 through April 2023, I'll be compiling that stakeholder input and preparing that stakeholder meeting report. After that, I'll be revising the draft 3-year plan based on that stakeholder input. And then I'll be scheduling the 30-day public comment period and subsequent public hearing with the Behavioral Health Board. Okay. For May 2023, I'll be revising the 3-year plan based on any additional information from public comment period and public hearing. And then from June 2023 through July 2023, I'll take the final 3-year plan to the Board of Supervisors for approval. And then once the plan is approved, sent to the California Department of Healthcare Services and Mental Health Services Oversight and Accountability Commissions as to finalize it and post it essentially on this to the state.
Thank you, Oliver. Can we have that emailed out to everybody on our email list? I'm assuming we can, Joe.
Absolutely. I'll send it over to Joe so that way he can distribute accordingly.
All right, thank you. So I want to make this open then for questions or comments from board members. Oh, I'm sorry, Debbie, I see your hand now.
Yes, I wonder, I always forget what % of the total budget, if someone here knows, do the MHSA funds account for? About, anybody know? Maybe that's somebody else's bailiwick who's not here.
That's a great question. And Kathy, by all means, please jump in if you like. I think it's 10 to 15%, but I could be mistaken, Kathy.
The last time I inquired from Behavioral Health Fiscal, it was approximately 13% of the total behavioral health budget. That may have changed in the past year, but that was the last percentage I received.
Thank you.
Thank you, Kathy. Any other comments or questions? Alyssa, I see your hand up.
Will you be providing a summation before you finish it off so that we can see what you're going to show to the Board of Supervisors? Like, is there a chance for us to review it?
Absolutely. I'll actually be bringing a copy and everything as well of each draft so that way you guys can see it.
That's awesome. Thank you.
Absolutely.
And that's helpful for us to do that in a timely manner so we can have a time to look at it as a board and discuss it. Tim, I see your hand up. I think you're muted, Tim. Can't hear you.
Yeah, thank you. We are supposed to make a recommendation on it at some point. We would be making a recommendation to both the HHS and the Board of Supervisors. So yeah, that's been an issue in the past. So it'd be great if we could work with you, Oliver, to time when that draft to the board is ready to go to the board so that we can have some input. The
absolutely, Tim.
Other thing I was,
I'm sorry,
the other thing I was
respond to that before Tim Ash goes on.
Oh, definitely. Yes, I definitely understand that, and that's why the Behavioral Health Board is going to be the first stakeholder meeting that I'll be holding.
Does that answer your question, Tim?
Yeah, the other thing that I just wanted to ask Oliver is if we check in, I'm a member of a local NAMI chapter, as are several other people on the board. And I'm just wondering if we could arrange with you to have a stakeholder meeting with us at some point.
That would be wonderful. Yes.
All right, thanks.
Absolutely. And I'll get your email too, so I can get a hold of you as well.
Yeah, that sounds great. The email is available to Joe.
Perfect.
Any other questions or comments about Oliver and the scheduling update, how this will proceed?
I have a question. This
Yes.
is Allison.
I'm just curious if you have a tentative schedule for the stakeholder meetings yet, or where they'll be, if you have a plan of reaching all of the areas of the community.
That's a great question. I'm still developing it, honestly. Since this is my first time doing the stakeholder meetings, I'm being really careful as to which ones I'm holding and all that. So I will get one prepared and it should be ready hopefully in the next week or so.
And that can be shared with Joe and he can send it out to us.
Absolutely.
Thank you.
So could we, Oliver, make any suggestions on where those stakeholder meetings, because we think about that a lot. Is that how we can participate and send you our suggestions?
Yeah, I'm glad you asked that actually. That'd be great actually. So what I can do is I can send a list over to Joe as well and he can distribute it as well. So that way you guys in your next meeting can discuss which stakeholder meetings we've done in the past and then see if maybe there's other groups that you guys would like for me to meet with as well.
Thank you. Tim Ash, I see your hand up.
Yeah, I just wanted, I wouldn't expect you to know this, Oliver, but one of the roles of the Behavioral Health Board is DHHS on their public outreach activities to basically to consult and advise. So I think that fits pretty well in with what Tim was just asking. To really fulfill that, I guess, we can talk some other time about it, but basically that would mean, possibly you coming to our board with a list of what you're proposing to do. It would be helpful to see what we had done in the past and then, get some input from us as far as, what we think should happen. I will say in the past, it was a really great job. It's been exhaustive as far as the number of meetings that we've had in this scope. So anyway, but doing it at a board meeting is really the way we should be doing it.
Yeah. Any other comments or questions for Oliver? So last, Oliver, we're going to do this in person, and will you be able to join us in person?
Absolutely. Looking forward to it.
So, so that material, Kathy would would present that the PowerPoint, so we could see it in our Zoom meetings, as well as now in person. Do we have the technology to make sure people who are Zooming in, like Steve, to be able to see the PowerPoint?
Like a hybrid system?
Yeah, that's what we have, a hybrid system. And so I think Joe is still working on the details, but that's a question that just came up to my mind. Joe, do you have any thoughts about that, or?
I really don't know.
Okay. So yeah, we need to connect with
Mr.
Michelle.
Chair?
And, I'm sorry, who?
Mr. Chair, this is Steve. I believe that with the OWL and with your hybrid system on Zoom, whoever the presenters are will be able to share the screen, and those of us on Zoom should be able to see that just fine. That's my experience.
Yeah, that's what you do at Board of Soup. So thank you very much. So we just need to figure out how to do it, and it shouldn't be too hard.
Definitely. I'll make sure to troubleshoot it too to make sure it goes smoothly.
Yeah, Michelle seems to be the person to talk to. She's a receptionist there. All right, if we kind of worked our way through this schedule update, any more comments or questions? I'm going to make sure everybody has a chance. Okay, then we go to our important or largest item on the agenda, and that is a presentation about the CSET, the Community Safety Engagement Team from the city of Eureka. Laura, you want to introduce this, and then we can go from there?
Sure. In 2019, I did a documentary and I interviewed the CSET team. And I was so impressed with all the work, forward-thinking work that they're doing in our county that I then volunteered, and have been volunteering with them for a little over a year. And so Commander LaFrance has put together a great team, and take it away, Commander.
Okay, thanks.
All right, I'm gonna share my slide if I can. All right, are we all good on that end?
Yeah. To me.
All right, so again, I'm Leonard LaFrance. As of a week ago, I was the sergeant running CSET. As of a week ago, I was given a temporary promotion to police commander overseeing investigation and special teams, which includes CSET. So yeah, it's been a little transition. Not much has changed. I'm still going to all the many meetings I go to every week and every day. But the only difference will be we have an assigned sergeant within CSET as well as backfilling for me, who's gonna have a lot more time to spend in the field and actually doing the work, which is really vital. So community safety engagement team, we were developed back in 2018 with Chief Watson. We had obviously a lot of issues with our homeless population, mental health issues. And so they designed a team to look at these issues and kind of look at long-term solutions. It kind of went initially in one direction, and then all of a sudden we shifted into a much bigger direction to where we are today. And it's when I think back, 4 years ago, 4.5 years ago when we started this program, we've really come a long ways in how we approach issues and what we've done to create a much more progressive and really reimagined way of policing. So the mission of CSET is it's a specialized team that's focusing on mental illness, addiction, and homelessness. That's really our overall issue. It's really hard to put in a 5-7 minute presentation about what we exactly do because it's so complex at times, or it's very simple at times, like giving someone a cigarette to de-escalate them, or figuring out how to get people back home to their families in North Dakota, and having support systems there for them. So we go from very simple things every day to very complex community problems with sometimes challenging solutions, yet we still work through the process. So again, 3 primary focus we do is mental illness, addiction, and homelessness. So this is what our staffing looks like, and I'll talk about staffing when I do the last screen on budgeting. So in theory, this team is supposed to have a sergeant, and that's I've been filling that role for the past since July of 2018 when this team was developed. We have a MIST officer, Mobile Intervention Services Team officer. That was initially a collaboration with DHHS. We left that name in place because it's been such a long-standing name since I think 2016 or 15. So the MIST officer focuses on homelessness and mental health primarily. We have a waterfront ranger. We have a second waterfront ranger who is Measure Z funded. We have a community service ranger. So they are a non-sworn officer who patrols our parks and waterfronts. We are supposed to have an Old Town officer who would be down in Old Town working with community partners and addressing any issues in the Old Town area. We have a volunteer homeless liaison. We have a kind of a 3.5 tier system as well, or prong system. We have CSET, we have Uplift Eureka. Uplift Eureka houses our outreach workers, and they also house a multitude of programs. For example, this week is Pathway to Payday, where we're connecting people directly to employers and showing how to do resumes, write resumes, take interviews, and actually have real interviews with real jobs. So Uplift does we could do a whole separate presentation on Uplift for a couple hours, a lot of good work. Then we also have the brand new mental health component of our city, which Jacob Rosen's obviously on the phone call, and I'm sure you'll want to have him come back later to talk about care. And then the other prong we're eventually going to have is a medical component where we'll actually have a medical provider, likely going to be a paramedic operating at an EMT level or a basic level, providing medical care in the field. And then again, like I said, our newest addition would be the managing mental health clinician, Jacob Rosen, who's developing the crisis alternate response team of Eureka. He was hired August 1st, I believe, and we've been developing this program since about January. I won't go into too much about it, but in theory, we're looking at different responses to people in crisis or mental health issues or social issues using people other than law enforcement, which in many regards is much more effective, but also not being naive to believe that they can only deal with it on their own. And sometimes you will need a co-response with law enforcement. So that's our general staffing. So some basic pillars we follow, and I'll talk about our pillars, our principles, and our strategies, and go a little bit about our data and then our budget, and I can answer questions. So some of our pillars, 1, community partners. We need each other. This is a community approach. We're just a very small piece of the puzzle, and we are just a small slice of the pie in this bigger equation of addressing these issues of homelessness, mental health, and addiction. Connection. We want to connect with every member of the community to reduce negative impacts and create positive long-term outcomes. Again, we're trying to really think forward thinking, go ahead, what are the outcomes that we want, and how do we get there? Accountability, compassion, and outreach. We have to balance all those things together. If we have too much accountability, we grind people in the ground, they'll never get off the ground. If we have way too much compassion, we have chaos. And so we have to balance the two. There's no simple solution on this. I can't give you a book and say, hey, this is how it's done. But it's a challenge, but that's a principle we try to live and die by, is balancing accountability with compassion. And then underlying causes or correlations. So we want to go upstream. By going upstream, eventually we're going to prevent and address these issues. And the biggest component of this is looking at trauma, especially childhood trauma. As we're looking many years when I retire, how we truly want to address these issues, we have to start with the kids now and not later. So some of the principles we operate by: one, homelessness is not a crime, but criminal behavior commonly associated with the homeless community is. In Eureka, we have a lot of issues with crime with our homeless. And again, the fact that you're homeless living on the street does not make you a criminal. However, your behavior can. Focus on criminal behavior and causes behind crime. We want to really start peeling back that onion and find out what's causing the crime and how can we address it. Again, balancing accountability and compassion and outreach. That's put throughout our principles and our strategies, is that balance. And we really strive for it. It's extremely challenging, but we strive for it every day. Reach people in their own environments. We want to reach people where they are, not where we want them to be. So it is very unlikely that if I have someone down at Free Meal, I tell them to hey, go down and talk to someone at 720 Wood and then go over to the welfare office on Coster. They're not going to get there because often they're too disorganized, either because of mental health or addiction or both. And so we really want to find those folks where they are on the street or in a greenbelt, at an encampment, in Old Town, in a park, wherever they are. We want to meet them there and start addressing needs at that point. One size fits all approach does not work. If we have a one giant sloth that says this is the only answer, we're completely wrong. Everyone's an individual and you have to use those individualized approaches. There's no one size fits all approach to any of this. Cutting the red tape is a huge one for us. Government often, as a 22-year government employee, government creates a lot of barriers. For this type of work, we have to cut red tape. We have to remove barriers. We have to move people from point A to point Z as fast as we can because we have small windows of opportunity. We could have a 50-minute window where someone wants to get clean, but if I can't get them from the street to waterfront within that time period, I've lost them. And I may never get that window again. Or if someone wants to go get signed up for the coordinated entry or some other service, we have to strike when it's in front of us, be present for them, and get it done now, not later, because later is not going to happen. So some strategies we use: one, high visibility, proactivity, and presence. Our officers wear a different uniform. We wear black and tan pants, and we wear load-bearing vests to save our backs, and so we can take off our gear also to reduce some of the stress on our backs. But we are trying to be as highly visible as possible in the community and very, very proactive. And we'll talk about our proactive activity here in a second. Relationship building is huge. We want our homeless to know us by name. I don't care what they call me. It doesn't matter that there's a guy that calls me La Freak to make fun of my last name, but it doesn't matter because we still communicate and we still talk and we still converse and we still problem solve together. So a lot of our homeless have our phone numbers. They'll text us, they'll call us all times of the day. If there's issues, if a crime happens, we are fed information constantly by our homeless to address those crimes. But we also want to network with our community partners. So every single day, there's folks within the county I speak to. I talk to Betty primarily every day, Free Meal, the Mission, Salvation Army, really key partners we have that we constantly communicate. And if I have an issue, I can call them. If they have an issue, they can call me. It's pretty much any time of day, and we can get it done. We really focus on locations and individuals causing problems. So if we have a specific individual that's causing a lot of criminal behavior, say down at Free Meal, we look at as a team with our outreach workers and with Jacob and say, what's the actual causing this issue and how do we approach it? Do we use an enforcement method? Do we use an outreach method? Do we use both? What's the best way to handle that? We also look at locations. When CSET started in 2018, we had about 600 calls for service a year at Free Meal. We reduced that by about 2/3 now, just by pure presence and working with Free Meal staff to address any issues. Again, looking at long-term solutions. We want to not just, we're going to fill short-term solutions, address an issue right now, but we want to find long-term. If a long-term solution is getting an individual back to their family who wants them and cares about them and wants to get them into rehab in a different state back home, then we'll do it. If we have an individual who's a sex offender and can't go to rehab here locally, then we have flown people down south to places that will accept them. So we're thinking about bigger picture. And again, we're cutting the red tape out of all this and being very, very, very creative on dealing with this. Connecting people with resources, not only public sector, but it's government, non-government. It doesn't matter who they are, if they're involved and want to be actively involved in helping us address this problem, and actually being active, not just talking, but we want people taking action, not just coming to meetings, saying something and nothing gets done. We want action because it's important for our entire community. And then we bridge a lot of gaps and fill a lot of significant gaps in our community within various services, mental health, law enforcement, social services. We fill those gaps. That includes if we have someone on the street, like a family, we can gap fill to get them in a hotel room for a couple of days until we pass them over to child welfare. We can get people food. We have gift cards. If people need clothing, we can make that happen. Pretty much there's nothing that we won't try to gap fill as long as it's legal, ethical, within policy. And not against the law. So if I don't get fired or arrested, I'm probably going to try it. And so even if we take people to jail, I've had many conversations en route to jail, talking to people getting to rehab centers. And so we've had instances where we bring people in jail, they sober up about 4 hours later, and we pick them up outside, coming out of the door to go to rehab, to go to waterfront recovery for detox, and then we hand off to other services. So just because we're arresting people, which we should, because we should hold people accountable, doesn't mean we're also not going to take outreach efforts with them to connect them with services. So functionality, there's primarily 3 functions that we do. Again, I can't go into all the weeds because they'd be here for hours and you guys are busy. So 3 things: proactive engagement, response to calls, and then operational and special projects we work on. So proactive engagement, we're in the field a lot, or the team is. They are constantly building relationships with everybody, the homeless, business owners, network with partners. That is key to our foundation, is that human connection. The fact they can see us, call us, have a direct line to us is beyond vital to doing all this work. Doing outreach and going upstream, again, with those connections built, we're able to say, hey, Bob, you're not doing well. We care about you. Have you thought about option A, B, C, D, or E, and how do you want to get there? And how do we help you get there? Obviously, being out in the community, we're addressing negative behaviors. It's very common that people that in the homeless community that work with us, they know us. If they're involved in a unlawful activity, they see us. They usually put their head down, say, sorry, LaFrance, and they stop doing what they're doing and they move on. So it definitely helps with getting compliance with laws. But also that relationship, again, leads us towards doing outreach with them. And de-escalation, we see our clients often in the community. They're in an altered state. It could be due to mental health or addiction or both, or something else. And so for us, those relationships we're allowed to de-escalate, or allows us really to work on a de-escalation and diffuse people in the field to, again, divert them from creating a later crisis or going to crisis later, which then resorts to a full-on response for police, which results in a 5150 hold, which then correlates to them going to the ER and then overloading our system, and then going to SD, which overloads that system as well. So response for calls for service, we respond historically to about 30 to 40% of all mental health calls for the city of Eureka. So out of all the 24 hours, 7 days a week, CSET, they primarily right now are working 5 days a week because our staffing is really short, but responding about 40% of all mental health calls for the city of Eureka. And those 2 take time. People in crisis as well, that kind of goes into mental health. But if someone's in crisis, suicidal, homicidal, usually our team will respond in lieu of patrol or with patrol, and we'll take over. Everyone on the team is all the officers on the team are trained negotiators. And one of our officers is on the negotiation teams for the county. And so we handle a lot of people in crisis calls that most people will never see at a higher level. We do a lot of agency assists with the county, everywhere from behavioral health to child welfare to public health. We get calls today saying, hey, we're looking for so-and-so to just because. And so we go and locate them, and we make the connection with the case manager, and then we hand them off to the staff. That's a very, very common occurrence. So if we don't find them, it doesn't benefit anybody. We assist a lot of other agencies as well. I talked to RCAA today looking for a client, and we were able to locate them fairly quickly. We know where most of our folks are, so we're able to quickly connect people with their appropriate agencies and case managers. And obviously we assist patrol a lot because we're about 30% short on staffing at Eureka Police. So we obviously do respond to calls for service. Again, we primarily try to handle those calls that are mental health related, and then obviously our homeless calls that come in because we can have more time to actually address those than just going call to call to call. So operations and special projects, we do a homeless survey every 2 years. It's a 38 question survey. We get a lot of very, very good detailed information on this. We use it for grant writing. We use it for our Measure Z support, for various things that we do. We have this data. My opinion, is probably the best data we have for Humboldt County for at least for the homeless population in Eureka. And if you want, I can send it to you later and you can send it out. I think Robert Ward sent it out last month or a couple months ago as well. We do address major encampment issues. So again, we're balancing compassion and accountability. There's a lot of hype a couple months ago when we addressed the HCOE encampment. If you read the papers or heard what people said, you think it just happened on a whim one day, but it's not how we handle things. We do several months of outreach, entering encampments with our officers, with our mental health clinician, and also with our outreach workers and other community partners. We continually offer services to folks and connect them as much as we can, or as much as they desire. And then at the very end, when we say we're just done, we have to do something because the behavior is so negative, we have to address it. And so when you do any kind of large cleanup like this, we usually have months and months upon months of proactive outreach with these individuals. If they do want services, we'll connect them, but eventually we have to address the negative behavior. Every year we do a service and barbecue down at Free Meal. So we collaborate with St. Joe's or Providence, with St. Vincent de Paul, free dining facility, Eureka Police, and I'm missing one, Uplift Eureka, and I may be missing another one, but we do a barbecue where we're down there actually barbecuing for the community being served down there. And then we did our second service fair. We did our first one before COVID, and we had our last one, I think almost a month ago now. We had more than 30 service providers. It's really a chance for people to, one, connect with our homeless population, again, bring services to where people are actually at, not where we want them to be, and also gives a chance for folks that are working in this community to also network and communicate and share information, which is not always a common thing. And there's a lot more special projects that we do. And obviously we assist our community partners. So example, Salvation Army, if there's an issue, we assist them. That list goes on and on and on. I think we have around 50 partners we work with off and on throughout the year. But really there is no barriers for us to helping people as long as we have, again, we're not gonna get fired or arrested. So some quick data for you. So I track a lot of data because data obviously drives funding. It also keeps you going and also gives feedback to what we're doing. So a couple data points here. So our response to mental health related calls for service, we track these. So in 2020, CSET responded to 170 mental health calls. In 2021, 404. 2022, we've done 169 so far. 2022 is a little bit, numbers are a little bit down because we were without a missed officer, which is our mental health and homeless officer, for several months. And we finally got a new one as of about a month and a half ago back up and running. So that number is going to be low. So for EPD in 2020, we handled about 30% of all these calls. 2021, 43%. And then 2022, we're at 22%. That's total. But with the missed officer currently in that role, we're back up to about 45% now, where we should be. And again, mental health calls can be very lengthy, can be very detail orientated. It could be a lot of de-escalation. It could be a lot of bringing community partners. The list goes on and on and on how critical those calls are, because the results, if someone's truly altered, could be a significant use of force, which we obviously do not want to go in those scenarios, but we want to have long-term outcomes for those. So we take our time. So individuals placed on holds by CSET. So in 2020, we did 91 holds. In 2021, we did 82, and this year we've done 15. We've been making drastic efforts to reduce mental health holds going to our ERs and over to SV, which are overburdened. So in 2020, of all the mental health calls we went to, we placed 54% of them on holds, and we were to divert 46% of them. In 2021, we held 25% of those people on holds, diverted 75, and this year so far, we've only held 9% of those people on holds, and we've diverted 91% of those folks. Diverting means either de-escalation in the field or calling in other resources, or if we're borderline, they might meet criteria, we'll call our partners over at Same Day Services or CSU. We'll talk to the staff over there. We'll bring them over. They do an eval over there as well. And so we're trying to have the best professionals looking at these folks to divert them away from a hold if we don't need one. If they need to go on a hold, they go on a hold. But again, we make every effort right now to avoid placing people on holds unless they absolutely have to. We did the CIT training last week, which was amazing, run by Kelly Johnson. I also teach a class for law enforcement on running 5150 holds, and the best way to ask questions, actually get the best hold you can to make sure we're doing the hold is going to be the is going to, one, is going to be upheld, and then two, if we could divert, how do we divert away from that? So we also assist the county with a lot of holds, a fair amount. I don't have 2022 data, but in 2021, we assisted them. So they actually call us to go out, respond either to sempervirens or out in the field with 20 holds. And this year we've done 12 so far. So we're on the same pace to have about the same number. That's where the clinician is primarily writing the hold, and we are either doing the de-escalation or the transport. But we're out there quite a bit with behavioral health staff. Warm handoffs to substance abuse treatment facilities. This is primarily waterfront recovery, but we do work with HRC, Crossroads. We have flown people out of the area. So in 2018, we started in 2018 in July. So this is only half the year. We did 8, went to 74, 57, 63, and this year we've done 20, which has been a much more challenging year, again, because of staffing issues, but also finding folks that want to go to rehab right now has been very difficult. Even talking to other partners, same difficulty. The ones during COVID, we have that wanted to get housed or go to treatment. We have got those people in those facilities. It's a really hard population right now in Eureka. So in total, in the past 4.5 years, we've done 222 people warm handoffs to treatment facilities. I think it's a pretty impressive numbers for a bunch of cops out there just making human connections. And then the big one for us is officer initiated activity versus calls for service. Our number we want is about 80% proactive activity. This team is supposed to be proactive. We don't want to handle a ton of calls for service, but we also want to, if we do, we want to make sure they're mental health related or homeless related, because those take a lot more time and energy. So in 2019, 5680 for officer initiated. So they actually went out there and made a contact with somebody or went somewhere. And then we did about 1,000 calls for service. So about 86% were proactive. In 2020, we dropped about 81% proactive. 2021 during COVID, we inundated with a lot of issues, a lot of calls for service. You saw our mental health calls went through the roof. We were about 67% proactive rate, which isn't great, but it was a definitely huge decline from the year before. And currently in 2022, we're back up to about 82% proactive. Again, proactivity for us is beyond vital because when we're out there talking with people, talking with partners, we're building human connections, which is really the key foundation to all the work that we do is that human connection. Then lastly, we'll talk about the budget for this program. So again, we have a sergeant that is currently being backfilled by one of our rangers, Ranger Ross. He's conducting his job and backfilling for me, which is a good chance for him to have a little more exposure to running a program, looking bigger picture. And the salary for that's about $100,000. Our missed officer is funded by Measure Z. That's been filled right now by Officer Jamie Clark. She is new to the team, but she's been working with CSET over the past year or so. So was pretty much ready to go when Officer Swanson, who really developed that position, and he did amazing work for 4 years. And he really set the bar very, very high for that position. And we're happy to have Jamie on board. We're very, very happy that Officer Swanson was so effective in that position. We have an Old Town officer that's currently vacant. One of our rangers is Measure Z funded. That's currently Ranger Ross, but he's also the acting sergeant. We have a second ranger position, which is currently vacant out of the general fund. And then we have a community service ranger. We filled it last January, and she came to us from behavioral health. She worked on sempervirens as a mental health worker. And so she filled that spot for us. And then here, probably the next couple of months, we'll be filling a community service officer role, which will be a combination of an outreach worker, case manager, and an office assistant for myself and for the CSET sergeant. So that's really CSET in a nutshell. Again, when you look at the salaries, that is the top step, plus a 14% increase for a post advanced certificate. Those are really, really extremely high numbers right now because most people don't qualify for those. But in general, our program is about 500,000. Of course, we're not adding benefits. We have obviously vehicles, but if you saw my vehicle, you would hope I'd get a new vehicle soon. But there are other costs as well. But just from a salary standpoint, we're around 500,000. And I'm happy to answer any questions I can.
Great, thank you. All right. Thank you very much. Tim Ash, I see your hand.
Sorry, I had trouble unmuting. Yeah, I just wanted to ask 2 questions and then a comment. One is if you go to homes regularly, to private homes? And also, is anyone following the outcomes for the folks that are diverted in terms of additional, further contacts in the, close in time? Those are the two questions. And the last thing I just wanted to say is really congratulations to your team. There's really no doubt in my mind that your team saves lives and needless misery, but I'm sure you save lives doing what you guys do.
I appreciate that. So yeah, for homes, yeah, we're not restricted to. So if we have a mental health call of someone in crisis or a welfare check, our team will respond out there. And again, there's some obviously for law enforcement or any government agency to enter the house, there's legal authority. And so we work those angles. We do respond to residences. It's not just our homeless population, but we, especially during COVID, we really shifted our team from really primarily focusing on homeless to the entire community. So for a while, we had just assignments just to certain beats of the city. So just like the Waterfront Trail, Old Town, any homeless problem. But now anyone in crisis, you will get, usually if we have our units available, we will actually respond out. Even as my current role, I'll throw my vest on if we need another person, because we know that often if we send a couple officers out there, they may not make a connection. We've learned, so you have to tap in, tap out, either trade negotiators or you switch your contact person. And usually the second person has some kind of, builds more connection, which is kind of weird, but it's something we've learned. Even with clinicians we've seen, they come out with us and most people don't want to talk to them in the field when we're present, and they'd rather talk to us, which is odd, right? Because we're cops. But I'm not sure if it's the privilege of being a law enforcement officer. So the fact that we're out there treating them like they're human beings, that we're caring, but we also have a position of authority. And so that connection definitely helps to de-escalate people. It seems like a bizarre concept and some people probably don't believe it. But if you spent a day or a week with us, it's pretty shocking with the stuff when I think about what we've done. And I mean, we've had people with knives to their neck that want to commit suicide. We're able to, throw a pack of cigarettes over for a knife. Very simple stuff, but those are the outcomes we're working for. As for outcomes, we do follow up with individuals. So especially once Jacob team is up and running, we'll have more follow up with those folks. But we have our clients, we know them well. So if we do believe we need follow-up, we'll usually connect with our outreach workers, or even if it's a county follow-up, we'll contact with behavioral health, work with them. And then obviously with Jacob coming on board, we will say, hey, I have person A, B, and A, B, and C. Here are the different things we had. We feel comfortable with you going out there with your team, or hey, we'll go out there with you and we'll do a warm handoff with you. We'll tap in, tap out, you step in and we'll back out. And we don't need to be here anymore. And so there's really no limit to what we're doing besides just don't get me fired or arrested. So
I have one other question is, do you have any ideas of why your numbers were so high in 2020? I mean, obviously the first year of COVID, but why?
Are you talking about mental health?
Yeah.
Honestly, I don't know. We saw everyone across this just in the many meetings I go to, everyone across the county saw those numbers spike. I'm not sure if it's just a lack of resources or a lack of unknowing, or we have more people now in their homes that aren't, being productive all day, or going to work and having a sense of purpose, and therefore there's a decline with mental health. I don't know, but all I know, we saw those numbers spike, and at one point, I think it was April of last year, we hit like 130 mental health calls. We were like 16 holds in 1 month. So every other day we were at the ER with someone on a hold, despite trying to divert them. But we definitely saw a lot of our folks that are on the street, I think, did better than the folks living in homes. And so, which is kind of odd, right? But if you think about it, I mean, most of them, nothing really changed during COVID for our homeless population. Besides some services changed, some of the stuff like down at Free Meal and other service centers changed, but really not much changed for them. But if you're living in a house, whatever your normal would be, whatever normal is, definitely changed to something different. And I think that probably pushed people also into further crisis.
Thank you.
Thank you. Alyssa, was there a chat information or question that you wanted to share or able to share?
Well, it was really, Connie provided some information. She said that Measure Z funded this program, $499,000 in this current year, your tax dollars. So that was just really great to be able to hear that.
Yeah, and so besides like our CSET program, this also funds, so Jacob's position for this year, and also funds 2 outreach workers, the homeless outreach workers for us, and a uplift diversion coordinator as well. And I believe a couple other positions in a small, we have about $15,000 for a stopgap, which means that if Jacob has an issue, I can immediately take my credit card and go purchase something, or if we need ponchos or need a hotel for somebody. We have a very small amount, but we use it very, very effectively for such a small amount of money.
Okay, I see a hand up from a member of the public, Katie.
Good afternoon. And first, I just want to say I am so thankful for the CSET program. And I think you guys do amazing work. And I think that our community is much better off having you guys with us in the community. My question is, I wonder if the presence or absence of anosognosia is being tracked. And the reason I ask, and I'll say what that is, which is lack of awareness of illness, is that my little soapbox is that anosognosia is actually the #1 reason for people not seeking or staying into treatment. So even above medication side effects or, bad experiences with psychiatrists in the past, I mean, there's a bunch of other factors, but 50% of the most severely ill psychiatric patients that have schizoaffective disorder, schizophrenia, and bipolar disorder have anosognosia. And so they are, I'm just guessing, are a lot of the folks that you guys are interacting with, and I see at the jail for competency. And so I'd be curious what your sense is on how many of the folks you have are have anosognosia. And I had the same question Tim Ash did about whether there's outcomes data specifically on when people get repeats, like having to have more contact with the CSET team, if it's tracked what went wrong as far as like where the disconnect happened between the last time they had contact. And so that then there could be some, I mean, I would guess DHHS would be very interested in being able to track of the folks that are not seeming to get out of the cycle of homelessness and severe mental illness. How are they?
Katie, I'd like you just to simplify your 2 questions.
Oh, I'm done. Thank you.
Okay, Leonard, however you want to respond, huh?
I got it. So, see, I have actually read some of the research on this. I'm definitely not an expert on it, but I have read some of the research. We don't track that. I know that Jacob coming on board will start tracking it more. Based on our last homeless survey, I can't remember the exact number, even though I'm a data guy. I think it was part of the survey we asked, you've been diagnosed with, treated for, supposed to be taking medication for mental health disorder. I think the response this year was 49% said yes. And then we had like 11% nonsensical. My opinion based on this work is 80% of our homeless population, not entire community, homeless population has a mental health disorder, and likely 80% is co-occurring with some kind of substance abuse as well. I don't track the data on that specifically. I'm hoping when Jacob has his team up and running, that's something we can track. We'd have to discuss how we would track that, either by, I'm not sure if it'd be, I don't know how we work that, but I'm sure Jacob could figure it out between the 2 of us. I'm a data guy. I know how to collect the information. I still know how we would approach that. But I think it would be good to have, because I agree the numbers are very high, and we see folks all the time that we'll repeatedly take on holds. Again, the battle is, we'll hear from one side, hey, it's not mental health, it's drugs, and then we bring them to recovery. Well, it's mental health, so we can't do anything. And so then we backdoor the system by getting a felony or misdemeanor case on them, which again, we're working the system because it's not perfect, and then we'll catch them on a non-comp. We have an individual right now who had 88 calls for service from June 1st to October 13th. And we finally got the individual on a felony criminal threats. And now that the public defender asked for a non-comp on them. So in theory, they'll probably move hopefully towards conservatorship or something else where they need to be. But again, we're trying to function in a system that has a lot of gaps. And these are very challenging individuals. Either way, we'll get the outcome that we want. I would just prefer to go not through the courts if you don't have to, but unfortunately, sometimes we have to use that.
So just to sum up, you're developing the ability to track the repeats.
Yeah, I mean, we can, so if I went to our RMS right now, our records management system, I can get a spreadsheet of all the contacts for somebody since our RMS has been in service. And so we can show that, hey, we've talked to this person every single day. And so that data is important to us because when we do write a hold, or if we do a criminal case, we'll actually create a spreadsheet. And so say if Jacob was a clinician and I sent him over a hold, and I had a 10-page spreadsheet of calls for service for this person that are summarized for each call. That's pretty impactful. So we do track that. But again, correlating what's happening between the lines, we don't really have that yet. It'd probably have to be more us looking at each case by case and then kind of coming up together saying, hey, what do we think is happening here? It hasn't technically been happening on a large scale. Obviously, we have many MDTs within our own agency. And so we do discuss the key problem individuals or people are having issues with. So we do discuss the correlations, but again, overall, we don't, as a bigger picture, we don't track that. It's more individually based.
All right, thank you. I see Allison, your hand is up.
I think you answered my question as well, but I just wanted to say how valuable this presentation was to all of us. And I really enjoyed the data piece. My question had been, going back to that warm handoff slide where there were, I believe, 222 people. I was wondering if you had an unduplicated total for those, or if they're the same people over and over. So
yeah, I can answer that. So we don't, when we log the data, we don't necessarily put names with them. We don't want to start tracking that as in with personal names. We know we've had folks in there multiple times. We know we have some folks in there, actually a gentleman over there who wouldn't mind me saying this, but Jamie George, he's a manager over there. And he was one of the first people we got in over there. And he's doing amazing work now. Actually, just saw him a couple weeks ago, gave me a hug, and we took a photo together. He posted on Facebook, and it's really cool to see that. But we have obviously repeat people that go in. I believe the data now is 13 to 21 or some ridiculous number now. It's definitely gotten bigger than it was a couple of years ago. But it's I guess it's important to know how many duplicates there are, but really the outcomes we want are people getting better. And so if I have to put someone in rehab 20 times, it doesn't matter to me. I just want to keep moving forward to make their life better and the community better. But it is really cool to see folks that we've worked with on many ends, on criminal issues and on outreach issues, to get clean and then doing amazing work in the community. It's just cool to see.
That would also be a great data set to see the positive outcomes. Yeah. Thank you.
Yes, Jacob, I see your hand.
I just wanted to add on a little bit. I won't go into too much of a presentation on CARES. That would be a whole other day. But as to the data tracking, part of what we are implementing with our electronic health record system.
Having trouble hearing you, Jacob.
Oh, how is this?
That's better. Just also speak more slowly if you could.
Will do. So part of what we are developing in CARE is with our electronic health record system is a method to track a lot of this data. And so as far as being able to track anosognosia, being able to track outcome data, being able to track repeat clients or repeat contacts, and who we are able to do warm handoffs with and where those warm handoffs are going. Is all stuff that we are including in our outcome data that we'll be able to track through a combination of just functions in the electronic health record system, but then also going and doing chart audits. And so we will be able to build out a much richer data set when we're able to kind of get that up and running and then combine it with Eureka Police Department's data from what they're tracking.
Okay, thank you. Other comments or questions from board members? Don't normally do this, but perhaps there's a staff person who would like to comment or question. I want to go back to this, the importance of understanding the repeats. A lifeguard can save 10 people from drowning or one person 10 times. And that's kind of the way I see understanding that data and where to focus and what's going on. I know both of you know this, but that's kind of the way I think about it in terms of the importance of that information. All right. I just think your program is wonderful. I'm so glad that you're doing it. We can all learn more from it. Thank you. Thank you very much for what you do and your dedication to that, Leonard. I do value that very much. So if there are no more comments or questions, then we'll move on with our agenda. Debbie.
Oh, sorry, trying to unmute. Again, I think it's a wonderful program. I'm thrilled to hear about it, really. Well, I just want to make a comment as a family member for over 20 years. The irony of having to have things get to such a point where the police have to be involved before your person gets help. I mean, the police situations have been so helpful in my situation over the years, and I really appreciate especially those people who are CIT trained and sensitive. But again, it is so ironic that we can't somehow manage to help people before they commit a crime, as you said, Mr. LaFrance. So anyway, just my 2 cents worth, and thanks for being there, you guys.
Thank you, Debbie. I see a hand up there from Melissa.
I just want to say thank you. I was a part of the CIT training last week, and hearing all that information and this information is really profound to me. I think that my progressive heart, huge in social justice, got my MSW in social justice and disability justice, and here mental health justice with the Behavioral Health Board. I'm really strongly directed in one area, and in the amount of compassion and caring that you are expressing is profound, and I'm really thankful for it. Thank you.
Thank you, Alyssa. Tim, I see your hand up.
Yeah, I just wanted to ask, from your perspective, what have you guys done so far with the new AOT program that Jack is responsible for, and what you see in terms of the future of it as far as penetration and just overall usefulness for your job?
Sure. So day one, not day one, but whenever they came into Breeding, we actually had a meeting with their staff. We've done I'm not sure how many referrals now, but we have referrals ready to go. Also, we have a list of people that we have folks that would qualify for that program or be a good fit for that program. And so we do meet with their outreach workers, we meet with their managers, their clinician, actually helped us barbecue down at the service fair last month. And so if we have certain clients they're looking for, they call us, say, hey, we're looking for so-and-so. And we text them back, say, hey, they're right over here, we'll wait for them. And so we're more eyes in the ears in the field for them. When they first started, I'm not gonna lie, some of their eyes were pretty big when they went out to free meal, and you saw 10 people in crisis, and some of the behavior. It's a reality check of what the world that we're allowed to live in and be in with this community, which is not perfect, and it can be a little bit scary initially. But once you are welcomed by that community, it's not so scary anymore. But the folks over there have been very happy with them. They are showing a lot of compassion towards folks, but they also see the reality of folks that are where they're at, and really moving towards some folks are going to need to have that court mandated whatever it's going to look like for them, but it's going to have to happen. We have some really hard cases. But yeah, we're in constant communication. We text back and forth them or call them. And if they're looking for folks, we are happy to locate. Or if we just see them, we just say, hey, we just saw so-and-so, they're on Broadway right here wearing this, or we snap a photo, shoot it over to them. This way they know where they're at. And we often will hang out with them as well if there's an issue, a safety issue. But for the most part, it's been effective. Any new programs, especially sometimes coming out of government, I'm always a little cautious of because often we have these great ideas, but we have often there's zero fall through on the back end, or there's not funding set up to actually make these successful. So we're gonna use this as much as we can, and I think it's we need all options on the table. I just really hope that we are able to fall through on these folks and give them the best care that they deserve, and also for our community.
All right, thanks.
Thank you. Other comments? or questions? And again, I want to thank you. Your work is immense and very positive. I appreciate it, and also the complexity of it. You approaching it that way, I value that. With no other comments or questions, we want to thank you, Leonard LaFrance, and for your presentation.
Hey, Tim, can I say something before Commander LaFrance leaves?
Yes, you can.
Congratulations. I don't know that I'll ever remember to call you Commander, but congratulations on that. And I just want to just take the opportunity to say, I believe without Leonard LaFrance in this position or in the positions that he's been in the last couple of years, I don't know that this program would be as it is today. And I want to personally thank you for the work that you've done around this, because I think it's a lot, and I really appreciate it. So thanks.
Thanks, Connie. Yeah, you have definitely some key staff over there have been amazing to work with, and it's been quite the adventure some days, but it's moving forward, so it's good.
Hi,
Thank
this
you.
is Madison. I have a question. Thank you for that presentation. And I don't know if I didn't hear you or I missed the slide. Is there like the race breakdown of the people you come in contact with? And I'm just asking because I know we have a Native American, large Native American population around here, and then working with either my agency in CIDC, which we do with mental health and wellness, but not necessarily like crisis movement, or UIHS.
So we actually have the data. That's one of the a different presentation, but our homeless survey data. One of the discrepancies we have with not discrepancy. One of the things that we look at is out of our homeless population in Eureka, 13% stated they're Native American. And again, we don't confirm that, but 13%. Right. We look at the overall county. I think is at 7%, I believe, or maybe it's the city of Eureka, but there's a giant divide. And so we have worked with, especially with Yurok, Chief Greg O'Rourke, with Yurok Tribal Police. We've worked some with UHIS, but we've really tried efforts to connect with our Native American partners as well, our organizations, but we've definitely not been as easy as we would like. So before COVID, we had some folks writing with our team to try to connect people back to specific services or funding they have, but definitely has a little more challenging. It's been challenging in some regards. So if you have any input, just shoot me a phone number or an email, and we are happy to connect with you guys as well. And we're happy to have more partners to work with to address this part of our community that's really vulnerable right now. And we'd like to connect the dots.
Yeah, absolutely. No, if it's any way you can alleviate the pressure already the system has, with the different resources, that directly assist, with the American population, that definitely want to do that.
Yeah, absolutely. And I'll send somebody the survey data for 2022, but there's a gap that we're concerned about with comparison with race within our homeless population, and actually the data from the county. So we want to definitely eliminate all the homelessness, but that's probably not realistic. But how do we make dents in what we currently have?
Yeah, like if there's other resources to help assist for other people, and streamline them to the resources that we have here. Thank you.
Thank you, Madison. I appreciate it. All right, any other comments or questions before we move ahead on our agenda? All right, thank you once again. On item number 8 on our agenda is communications, and this is the opportunity for board members to share some communication issues, thoughts, questions, information. Are there communications from our board? Hey, Alyssa, I see your hand.
So I kind of already communicated to the board. I was very excited to be able to have the opportunity to be a part of the CIT training last week. Like I already said, I am very, social justice motivated and very civically minded. And I was unsure what was going to be presented, but what was presented was awesome. You know, it's like I said, I got my degree in social justice, and I work in disability justice, and this board is about mental health justice. And I went in there from that perspective to see what the theories are behind the actions, the policies, and the procedures and everything. And it was really awesome. I didn't find myself getting nervous or scared at any of the concepts being presented. It seemed like engagement was coming from incredibly educated perspectives. It was wonderful to hear what they were focusing on as being primary goals when it came to interacting with others, and what they wanted for end outcomes, and what they were trying to achieve. I felt, like I said, very profoundly honored to be there and to be able to be a part of that training and learn a little bit more about what's going on when it comes to policing. That was a long time dream come true, and I just want to say thank you to everybody who had a part in the CIT training, DHHS, and officers. It was great.
Well, thank you. I'm glad to hear that. Tim, I see your hand up.
Yeah, I just wanted to echo what Alyssa just said. I was able to attend some of the presentations last week, and it really was well done. And I've been involved in it for a while, not just last year, but the quality of the presentations and the strategy as far as the curriculum has really come a long way. The folks that have been working on that have done a great job. We've had consistent leadership for the most part, which I think the continuity has allowed there to be a kind of monitoring of what's going on, and that more of an ability to make it better. For me, the highlights were, as usual, Josh Todd, who's a former sheriff's deputy from the Marin County SO, and is now a mental health clinician, does a great job kind of speaking from the perspective of a law enforcement officer as far as how officers can do their job better in terms of understanding mental illness, de-escalate, etc. And then the other thing was the a presentation was made by Chief O'Rourke from the Yurok tribe, did a really good job of talking about what CIT means in the Native American communities. And just a little bit about cultural perspective. And anyway, that's a kind of a first time thing for that, that perspective. I think it was a great addition to the training. And finally, the best quote from the CIT conference was from Chief O'Rourke, and it was, "If you don't believe that Black Lives Matter, you're an asshole." So I kind of like that.
Thanks, Tim. All right, board members, other communications you'd like to share? Debbie, I saw your hand waving.
Yeah, thanks, Tim. I had a couple of questions, and I'm not sure if this is the time, but I'll just throw them out. Maybe they're coming up in reports would make more sense, but one question I had is, what is the total number of behavioral health clients? Somebody here knows that, I bet, per year or in a year, or, something like that. And the other one is, will we be hearing any more today about the crisis residential treatment project? I think I'm the one that's the N Street.
Right.
Those
we
are
talked about that, and Jack can always include what's going on with that.
Okay. Okay.
And is anything, well, I forgot your first question.
The total number
yeah.
of clients or client visits, I guess, or patient visits or whatever. Just
Somebody has that, right? Jack, do you know? Is that a
Yeah,
quote?
I think we have that somewhere. I
Yeah.
was just kind of gonna scan some emails and look for that, so I'll do that.
my guess was 2,200 because
Okay.
I was trying to find it. You know, I'm working on this League of Women Voters study, and I came across a document, but I didn't know if that was the right number.
Jeremy, do you know that?
I don't know the overall. I think in children's it's somewhere in the 800 children range.
Mhm.
So
Yeah.
and then whatever adults combined
Yeah.
with that. So
Okay, well that works with the numbers I saw, which I didn't know if they were right, but.
So I'm happy to comment on the crisis residential now or wait until.
Let's wait till the rest of communications. Jim, did you have something else? I see your hand still up. Oh, okay. I see your head saying no. I have nothing more to say.
No, yeah.
Any other board members, things they would like to share?
I can't raise my hand. This is Laura Montagna, but
Hi,
I
Laura.
just wanted to, hi, and I'm going to have to leave a little bit early, but I just wanted to say I went to the CIT training as well, and it was wonderful, and I learned so much. So I'm very grateful for Kelly Johnson, and that whole program is wonderful. And then also just to report that there was a small and mighty group of us that met to learn about how to run an ad hoc committee for the Behavioral Health Board. And so we should be hopefully having some more ad hocs working on specific items like the MHSA and jail services, et cetera, AOT, et cetera. So I just wanted to report that. And thanks, and I have to go.
Okay. Hey, thanks, Laura. I appreciate what you did to have that meeting on ad hoc. So, thank you.
Thanks.
Any other communications from the board? All right. I want to encourage you to remember and to share things with the rest of us. So we'll move ahead to reports, and that's item number 9. And the first one is the director of DHHS, and that's you, Connie. You're on.
Thanks, Tim. I think the first thing that I need to do is say thank you to you and actually all of the Behavioral Health Board for, working on the annual report, those of you that worked on the annual report, but also just you, your presentation yesterday at the Board of Supervisors meeting was really short. I think the board was, and I guess that was Tuesday, not yesterday, but the board's day on Tuesday lasted until like 8:30 that day. They had a really big day, and they took the time to talk to you about how important behavioral health is. There's a number of board members that have been participating in this group over the years, and they know how important behavioral health is in our community. So I just want to say thank you. Actually, I think I want to say thank you on behalf of them also, because they would be saying the same thing. Yeah, so I just want to appreciate your board for all the work that you do. Super important. And for us to have the number of members that we have right now is pretty remarkable. So thank you for that.
Yeah, the Board of Supes was really glad to hear we have a full complement,
Yeah, that was really good. And then I guess I could provide an update that's not an update of the navigation center. I can tell you that I continue to have conversation with the contractor and owner of the property. And I'm actually utilizing, the city manager and others to help, kind of push this along a little bit. They do have our draft lease, and is now, talking with their attorney about what it might look like. I'm trying to get a timeline of when we break ground there. That's really what I want to see, and that's when we really get to start having community meetings and such, and really start planning around that. So, yeah, so that's not really all that I have to report. And every time I have anything to report on the Navigation Center, I will be sure to update this group.
Okay.
It's going really slow.
So I was going to ask you, Connie, is there anything particularly that you find the most challenging to move forward without naming names?
No, well, I guess we need rainy weather so that so that the contractor isn't, building bridges, that they can spend time on building our building instead of building bridges and such. So
Okay, I'll try to.
They're extremely busy, and
I'll try to organize the prayer team on that. So.
Right, start getting that rain in so that they slow down a little bit.
Okay. Anything else?
I think that's it. I can't think of it. Oh, no, I guess I should add. A few of us from DHHS and a couple of CEOs from hospitals are going to Orange County to visit a place they call Be Well. And it is just giving us ideas if we were to expand or build new facilities, what that might look like here in Humboldt County. We're going November 14th through the 17th or something like that. So ask me again next month and I'll be able to, I won't be at the next meeting because I might be in Orange County, but the following month I can maybe provide some other information. I think Emmy has told this group that we've been working with the emergency departments from all the hospitals here locally about how we can better manage our 5150 assessments and such. So yeah, we're seeing what else we can do.
Thank you.
Crisis residential and all other things.
Yeah, I saw a presentation from Be Well at the NAMI State Conference, and they look great. Hope that you can learn things from that. Tim, I see your hand up.
We want to look great too.
Okay. Okay.
Yeah, I was just going to ask, actually, if it's too early, or if you could say what Be Well is, and then also what is the scope of the type of facility that you're planning to look at?
So you know what I can do? I can share with you the PowerPoint and brochure from Be Well in Orange County. I can give it to Joe and he can send it to the group. I want you to keep in mind that their population is 3.2 million. So it may look a little different. But I'll share that with Joe.
Okay.
Cool. Thanks. And
go ahead.
So will we be able to tell from that what the full menu of possible facilities is?
Yeah, I'm not sure if there's been discussion around waterfront recovery, wanting to do some other services. Has that been a discussion here or not?
We've heard it.
That's all.
So there's thoughts around sobering centers, all sorts of stuff. We just got to figure it out, right? In the past, sobering centers haven't been funded, and so that's a whole other issue, right? We have to figure out funding and staffing because we are at critical staffing levels right now, and if we think that we're going to add new buildings, where are we going to get the staff to actually do this work, right? So we need to be thoughtful about all those things. I can just say I'm happy that Connie Stewart and Cal Poly Humboldt is on board and going to visit with us, and we've been really working with them around getting additional staff. So, you know, the education piece and recruiting people to do this work is really necessary for our county.
You mentioned hospitals. Is psychiatric ERs part of what you'll be looking at?
No. But I'm struggling with the word. Maybe Jack, you can help me. But what is it's what we were, and I know if others were here, they could help, because Paul's been involved in all the conversations. But what's the other conversation we've been having with hospitals around crisis?
Like a triage center.
A triage center. Yes. Yes.
I think I had mentioned several months ago that the empath units that are being done, they are actual ER legally, and in terms of what they are, they're within a hospital, but they are set up for psychiatric admits, patients that are there on a hold. I just wondered if that was part of it.
We'll see. I don't know enough about it at this point.
Okay, thank you. I think we're on the going to you, Jack, AOT update, as well as maybe something about the treatment center.
Sure. I'll just want to, first I want to answer the question from Deborah. So there is about 2,000 active cases in adult behavioral health right now. So that's our number. Then I wanted to, there was a couple things, Connie mentioned one of them, but that Emmy wanted us to bring up. Behavioral health is considering a grant application for a potential rebuild of SV and CSU to expand services.
Cool.
So that's very exciting. And then we have a EQRO schedule, a EQRO review, which happens annually, is scheduled for November 9th, and we will definitely share how that review goes at future meetings. So those were a couple things that we wanted to share. The grant is a BHCIP grant for that expansion. So that is meaningful. AOT, it was good to hear the feedback from, I guess, Commander LaFrance today. And I'm glad that they are working so cooperatively with each other. And I certainly my understanding from their end is that they're working closely with EPD. So good to hear the other side of that. We still, I think we're at 7 clients. We haven't added any more clients yet. Most of those are either voluntarily agreeing to services, or we're in the outreach and engagement phase with them. I do feel, and I reported this last time, I think, that we're getting kind of close to that precipice on a couple of folks of going to court with them. But seemingly EIA is able to continue to engage with them at some level that they're not feeling ready to pull that trigger yet. But we talk about that at our meetings, and we're getting prepared for that end. So, but that particular piece of it, AOT hasn't happened yet. The crisis residential, really exciting. The building that, the house really that Willow Glen has selected, the escrow closed on that house. And so it is with, Willow Glen's management group, the purchase of that house. And so they're just working diligently to get plans together for remodel and renovation. And so hopefully that will start, pretty soon. Our contracts for that remodel with them is in place. And so we've got all of that together, which is great. And so we'll continue to update the board on, when any kind of groundbreaking is happening in terms of that remodel. But they did kind of revise their estimate a little bit to say that we had talked, July 2023 as an opening date. They kind of revised that to say late summer, maybe early fall for that opening. July 1st would be a really optimistic target. So I think late summer is probably more, or early fall is a more accurate one. So, but again, we'll continue to update on that moving forward.
Thank you. I see a hand. Katie, I'm going to go to a board member and then we'll get back to you. Tim Ash?
Yeah, I just wanted to say regarding the grant expansion at SV, and I don't know when might be the best time to do it. We might want to discuss it at the executive committee, but my thoughts on it right now is, I welcome any expansion, any improvements to the current facility, but in the back of my head, I'm thinking if we get the Medicare waiver and we're able to go beyond 16 beds at some point in the future, we could, potentially be looking at a, much improved and much expanded facility with, Connie made her comments about staffing. That's always an issue, but I guess similarly to the jail and the mental health beds there, I think at least if we have them in the community, we can always be working at trying to staff them. But long term, I'm hoping that we're looking at something beyond SV, strategically looking at what the future may bring in terms of reimbursable services, crisis services.
Thank you. I see a hand with Debbie. I will get back to you, Katie, but just wanting board members to speak first. Debbie.
Just a quick question about the crisis residential program. How many beds will that be again?
So that's going to be, it's going to be a 10-bed facility. The county will contract for 9 of those beds. So we'll, be intending to make sure we're filling at least 9 of those daily, and then, perhaps that 10th one as well.
And how long will people probably be staying there? Or is there a span of time?
Yeah, so there's 30 days is like the maximum that you can do without some kind of special authorization by the county. At that point, you can go to 45 days. I'm thinking, though, the average that I heard from Willow Glen and others is somewhere around 14 days, though, that people end up invariably staying there. So it just kind of depends. But I think some of it does have to do with resources after they leave, right? And so I think that certainly is, something that might increase the length of stay for some folks.
And it's voluntary, so people can come there themselves without being brought there. Yeah.
So it is voluntary, which means we can't keep people there. In order to be referred there, you do have to you do have to get some kind of county authorization in order to be there.
Great, thanks.
All right, thank you, Katie.
Oh, hello. So Connie, I'm so delighted with how many new programs are coming along, and I think it's super exciting time. I'm wondering, in the meantime, until some of these programs get going, if you guys have walk-in psychiatric, like, on the same day service, if you have a psychiatrist maybe through your contract with Traditions that could see people on a walk-in basis in order to, prevent people from developing crises due to running out of their meds, not being able to get into their appointments, and that kind of thing.
I do know that that's what same day is for, and I'm gonna let Jack answer that question because it looks like he was going to do that.
Yeah, thanks, Connie. That is, you could go into same day services to 720 Wood Street and they would have staff that would see you there that same day. If you're an active client receiving medications from a psychiatrist there, they can certainly make a call upstairs and get refills managed. If you have not been seen there, there is some ability, though I would say it's a little bit limited, but to have a psychiatrist same day appointment or at least a consult in some way. But if you really needed medicine, you could also get referred like to the CSU as well, and then I think they could handle it at that level.
So I would just put in the plug that when there was a walk-in psychiatric clinic, it was extremely useful. And that at least currently the public perception is that there's no psychiatrist on same day. So you can't get in right away. And I've had patients that were bumped from their outpatient appointment because they showed up like 5 or 10 minutes late. And I just mention it because in many other clinics, county mental health clinics that I've worked at, including in Sacramento County, we psychiatrists saw walk-ins. So if we were busy all day long, seeing patients all day long, and the psychiatrists would not say, oh, I can't see this one because they didn't have a full assessment yet, or, to do really like triage crisis intervention from a psychiatric standpoint. And I think that would be really useful. And maybe you could use your Traditions psychiatrists. So it's just an idea, because I think that would prevent a lot of the crises from escalating due to people running out of their meds or needing a med adjustment. So anyway, thank you.
Thank you, Katie. Any other questions or comments for Jack's report? Tim, I see your hand up.
Yeah, Jack, I was wondering, I don't know, I'm trying to remember back to a letter that Danette Kellerman sent to behavioral health. I don't know if it was addressed to Paul Bagnacki or yourself or both, but I was reminded of it by Dr. Wilson's talk about getting access to med change, and she was referring to a specific client, and there was an issue with getting medications in a timely way, and the person decompensated pretty badly. But there was a lot of stuff in that letter, and all our board received a copy of the letter, but I don't recall ever seeing a response. And I don't know if you're familiar with that letter, but I'm just wondering if DHHS has responded to her letter. It was coming basically from the public defender's office.
Well, my recollection, I do recall that letter. My recollection of that was that Emmy had talked, I don't know if it was in this meeting or executive meeting, about our limited ability to really communicate about specific client information or programs or treatment. And so I'm not 100%, but I feel like at least in that case of that email, that's kind of what we ran up against. But then we also had a conversation about just the normal, and I think this was an executive board where we had a protocol for the normal sort of route for grievances, whether those are done by the client or on behalf of the client, right? That those get routed through our quality improvement department, and those are sort of handled in that way. And so I think, that's sort of my recollection of the outcome of that email.
Yeah, that's my recollection from that meeting as well. Yes.
Was I don't recall that, but was if it was a HIPAA issue, was it related to our being part of the loop or Danette's being part of the loop. So I've heard HIPAA interpretations before that kind of all over the board on, you know, who can know about those sorts of things. I know I can see why we couldn't with the specific name, but I don't know about Danette.
But I think, Tim, that letter was sent to everyone, and part of our thinking was because of some of those issues, it should go directly and not immediately come to the board. It should go there first. That's my recollection.
Well, that's up to the client and the public defender's office, what they do. Then what DHHS has got different requirements.
And
yeah, okay.
just as a reminder to everyone, you can easily redact things like that. So I remember seeing that letter and thinking, I wonder why they didn't redact the names out of that. But because in typical legal, when I review discoveries, the office just redacts the identifying information. And by the way, we never did end up getting any response as far as what was done to mitigate that circumstance. And I think the board would definitely have an interest, I know the public would, in hearing in a redacted way what's being done to remedy that. Just like with the Steichen case, which is in the newspaper, I know none of us have privy to specifics regarding that case. But on the other hand, I think the board and the public want to know for situations like that, what was the glitch, and therefore what is going to be done differently in the future.
Thank you, Katie. I think we should take this. This really has to do with confidentiality, procedures, and I think the executive committee can go deeper into that and decide a way that can come back to the board. That's kind of where I'd like to go with it.
Yeah, I think that's a good idea, Tim. But I do agree with Katie that we need to know about those things, whether it's, you know, redacted or what, just to know how things are working. That's kind of our job, is to know how things are going and then make suggestions on how they might be changed.
Yeah, I agree as well. We just need to thread this needle or walk this line and figure out the best way to do that. I think we were on your report, Jack. I feel like we've moved quite a ways. Is there anything else?
No, I don't know. I don't have anything else. Thank you. I don't know if Jeremy had some comments.
I can just give a quick update on the crisis residential project on the children's side. Jack and I have kind of had a side bet about whose project is going to get finished earlier, and unfortunately there have been some delays in the children's one, so I think he's probably in a better shot to get the adult one completed sooner. But so Sorrel Leaf Healing Center, that's the nonprofit agency that we are contracted with for the children's crisis residential project. We are still moving forward with that. We're in the thick of the Medi-Cal certification and licensing and contracting process, which is all slowly moving forward. Unfortunately, I may have mentioned it here before, but as part of the process in working on their contractor and development for the site, they did find a bald eagle's nest on the property, which significantly impacts the timing of when construction out on the outside of the building can happen. I think there's like a 6-month breeding window that there can't be any construction outdoor around the nest. And so I think what that's throwing a wrench in the timeline for construction completion. They will have to assess when it comes time to start that construction to see if it's actually an active nest, if there are, and so that there are multiple timelines right now. It could push our project out to as far as 2025 of being completed. So that's certainly unfortunate, but there's not much anyone can do about Mother Nature and throwing a wrench in some of those plans. And so continuing to make the best plans that we can to move forward. They are also considering a potential change of scope to where at one point they had talked about doing 3 crisis stabilization beds along with their 9 crisis residential beds. They are finding that staffing regulations and requirements to manage the 3 CSU beds on the same site are posing some significant challenges, both fiscally and staffing wise. And so we are in some early conversations with the grant folks to potentially shift those 3 beds to all being crisis residential beds, and that be the primary focus for that facility. So that's still in the works, but we'll see what the decision is on the final use of those beds. So it could increase to a 12 bed crisis residential only facility is most likely what they're going to be going for.
Okay, thank you. I was a big champion of the crisis thing, and I'm sorry to see that might be dropped, And I know you were too, Jeremy.
Yeah, it certainly is. There's certainly some pros and cons to having that. I think it will make it in some ways a simpler and an easier process to get everything up and running for the crisis residential, and having additional crisis residential beds certainly will be helpful. I do think the crisis residential facility still is going to really help us be able to move youth out of emergency departments really quickly to get those services that they need. Like Jack said, the time frame for crisis residential with youth is about the same, usually 14 days up to 30 days for youth. And so they can certainly get a lot of the services to stabilize and then work with the families to return home and get the long-term services they'll need. So still is an exciting project. I think it's a much needed project. And but we're unfortunately hitting some snags that are making the completion of it look like it's going to be pushed out a ways down the road.
Understandable, and we are also excited about it. Any other questions or comments for Jack or Jeremy? So to the chair and the vice chair, Laura's the vice chair. I don't have a lot, but I do want to urge people. I think the email was out, an invitation to the Cal BHEBC, which is the Behavioral Health Board Advisory Committee, and they're doing a Zoom kind of training or information sharing on November 4 at 11 a.m. about board and care. And it looks like they have some heavy hitters coming to be a part of that. What's going on, where money is coming, what changes in policies are happening. So that's kind of what I needed or wanted to share. We can go on to our things called unfinished business or future. We'd written down here navigation center, and I think Connie has shared that, what she can share with us now. Any other questions about that? Then our next one, we wanted just to be updated on the care court, and it looks like that's still a ways out. I don't know if there's any, we have a lot of legal and issues still to go. Jack, do you know anything? Are we still in the planning stages?
Yeah, I think so. I think, there's what I'm understanding, there are those pilot counties that are, hopefully getting up and running within a year, and that'll really be a good example for us, about things to come. But I think we're kind of waiting and seeing how that goes. But Sharon, yeah, go ahead, Sharon.
Hi, that's correct. There's not a lot of information right now. We're waiting for the first 7 cohorts to go forward. So more information is going to be coming out. Right now, there just isn't much that I can update you with, but I wanted to put in a shameless plug. All of you guys sit in various committees and groups that are going to be hearing different aspects of Care Court as it moves forward, because it touches on so many different systems. So if you're hearing things in groups, I would love to hear about it from you. Shoot me an email or through Nancy or through Joe, just to share that information that we're all hearing. And that, as I said, it's going to be discussed in a lot of different venues. So at worst case, I'm hearing, the information twice, but that would really help us out a lot as we are trying to compile some of this information. And then as soon as we have updates, we'll bring it back, of course, to this group. It will be coming out, but those first cohort groups have to take the deep dive and see where we go.
Do you think that we need to wait a little bit longer for that kind of thing until the cohorts have something to report?
I think that it would be worthy to kind of keep it on your radar at least. You could certainly keep it on the agenda as a standing item. Because we are going to start to see the conversations coming out. So it's certainly worthy to have updates coming along so that you can track what's going on in these other counties. And that's going to be really important as we're evaluating it to go forward locally. What are they seeing? So I think it would be valuable to keep it on as an item, or at least, kind of on the back burner at the moment. But
Yeah,
we'll bring back any updates that we have.
No, I really appreciate that. So that's the kind of a thing we can just put it there, and what's new is shared. So, thank you. Do we have any reports from our ad hoc committees or other committees? I kind of skipped that on item. I didn't think we did, but I went maybe too fast on that. So I guess we're wrapping up. My clock says we're virtually at the end here. Any other comments or questions from everyone? Remember, we're having our next meeting early. In December. We don't have a meeting, so after November, our next board meeting will be in January. So,
Hey, Tim, I have a comment.
okay.
I just want to say that I watch a show that I watch occasionally. It's called Alaska: The Last Frontier. And it's kind of fun to watch it for me, but the last episode was it was very interesting. One of the people on the show, it's one of those reality shows for those who haven't seen it, set up in near Homer, Alaska. But one of the fellows on the show brought a bunch of veterans out to help someone do some work at their homestead, and they sat down with the veterans and the homeowners, and actually Jewel, the singer-songwriter, who's a relative, and they talked a whole bunch about panic attacks and PTSD. It was a big part of the show, and it was kind of nice to see that kind of thing happening. I don't think you would have seen it 10 years ago.
Yeah. Yeah, well, I lived there for 12 years, and I met once while I was there in Juneau, the head of the public health for Alaska, and he just said quickly, some people are having mental health crisis, they just want to change, and they think it'll get better in Alaska. And it's not the case. Well, thank you, everybody. Wanted to hear the Alaska stories. Thank you, everybody. Have a good day. The meeting is adjourned. Thank you very much.
Take care. Bye-bye.
Thank you, Tim.
Bye-bye.
Bye, everybody.
Yes.